Hey everybody, this is Dr. Medicine RX and in today's video we'll be discussing about erythema multiforme. So it is an acute, self-limiting, usually mild, relapsing skin disease that is clinically characterized by the abrupt onset of symmetrical, papular, urticarial and classic iris or target lesions. Or simply put, it is an acute hypersensitivity reaction that is characterized by variable skin lesions as well as mucous membrane involvement. So coming to epidemiology, it is observed predominantly in young adults and it is uncommon in children and all races are susceptible. Coming to etiology, the potential triggers, there are two main important potential triggers. One is viral infection, the other is drug causes. Other than that, we also have bacterial infections, fungal infections as well as allergic contact dermatitis. So in viral infections, herpes simplex virus is the most common cause of erythema multiforme and it also causes relapsing and recurring erythema multiforme. Other viruses such as mycoplasma, HIV, that is acute immune deficiency syndrome caused by HIV virus, adenovirus, CMV, cytomegalovirus, hepatitis B, infectious mononucleosis, lymphogranuloma inguinale, Milker's nodules, mumps, or poliomyelitis, psittacosis, variola, vaccinia, and varicella are also the potential triggers for erythema multiforme. Bacterial infections, a wide range of bacterial infections are known to trigger erythema multiforme, including rickettsia. In fungal infections, histoplasmosis is most commonly responsible. And coming to the drugs that cause erythema multiforme, these include antibiotics such as cephalosporins, quinolones, most importantly, penicillins and tetracyclines, sulfonamides, ampicillin, rifampicin. And in antifungals, terbinafine and griseofulvin. In NSAIDs as well, and anticonvulsants such as barbiturates and carbamazepine. Other drugs include antiretroviral drugs, antihypertensives, metals such as gold, mercury, arsenic, iodides, and etc. Coming to allergic contact dermatitis, certain agents such as poison ivy, topical medications such as neomycin, sulfonamides, balsam of Peru, and certain environmental substances such as nickel, formaldehyde, and other agents such as latex in rubber gloves and dinitrochlorobenzene are all known to trigger erythema multiforme. Coming to pathogenesis, it is unknown. HLA-DQ3 is reported to be associated with post-herpetic erythema multiforme and it has also been suggested as an additional diagnostic marker. And other human leukocytic antigenic groups have also been reported as markers of recurrent erythema multiforme. And the damage to the epithelial cells is via cell-mediated immunity. And during the early phase of the disease, there is influx of macrophages and CD8 plus T lymphocytes, and they release a wide range of cytokines that mediate the inflammation and result in the apoptosis or cell death. Coming to subtypes of erythema multiforme, the first one is erythema multiforme minor, where we have typical targetoid lesions and they involve the acral areas and also lip, but there are no mucosal erosions. And if there are any mucosal erosions, any one mucosa is involved, especially the oral mucosa, and the lesions are also going to be limited. Then erythema multiforme major, where there are typical targetoid lesions with acral skin involvement and extensive mucosal erosions. And then atypical erythema multiforme major, where there are giant targetoid lesions with central distribution and prominent mucosal erosions. Then mucosal erythema multiforme major, where there are no or minimal skin lesions but there is prominent mucosal erosion. And continuous erythema multiforme, where a series of often overlapping attacks of erythema multiforme occur. And persistent EM, where there is widespread therapy resistant EM and it persists for many months or years. Coming to clinical features, usually a prodrome is absent and sometimes there can be variable symptoms such as fever, myalgias and arthralgias. And usually there is a history of preceding HSV infection. It can either be labial, facial and rarely genital. And the onset is abrupt with multiple lesions appearing within 72 hours and the lesions remain fixed for 7 days or more. And in erythema multiforme minor or simplex, we also see papular or urticarial lesions along with the target lesions in acral distribution. And the typical target lesions, they show at least 3 concentric components. The first is the central dusky erythema, purpura or blister, and it is surrounded by a middle ring of pale edema and as well as an outer well-defined ring of erythematous halo. So the sites involved include palms and dorsal aspects of hands, feet, elbows and knees, and they are involved symmetrically and they may spread more centripetally towards the trunk. And in erythema multiforme lesions, they usually fade in 1 to 2 weeks. Usually they remain fixed for 7 days and then they start fading in the second week. And sometimes they leave a dusky discoloration and recurrences are common. And the lesions, they are usually monomorphic in a given patient, and variations in morphology of lesion such as the center becoming purpuric or necrotic or changing to a vesicle or bulla can also occur. Cobnus phenomenon can also occur, and the mucosal lesions, severe mucosal involvement is characteristic of erythema multiforme major, and the primary mucosal lesions are vesiculobullous and they rapidly develop into painful erosions that involve the buccal mucosa and lips, and less commonly the ocular and genital mucosa are also involved. And the mucosa on the lips, the erosions, they rapidly become covered by painful crusts. And systemic symptoms, they are almost always present in erythema multiforme major, and these include fever, asthenia, arthralgias, and rarely pulmonary involvement. Coming to investigations, the erythrocyte sedimentation rate is elevated, and there is also moderate leukocytosis, and acute phase proteins are also present, and there is going to be mild elevation of the liver enzymes. On histopathological examination, there is going to be basal keratinocytic necrosis because of the CD8 T lymphocytes and the macrophages, and there is going to be mild spongiosis, that is the edema of the stratum spinosum, and focal vacuolar degeneration of the basal keratinocytes is seen, and superficial dermal edema and a perivascular infiltrate of lymphocytes is seen in the dermis. And when you do an immunofluorescence, granular deposits of IgM and C3 are seen around the superficial blood vessels and focally at the dermoepidermal junction. Coming to treatment, it usually runs a self-limiting course, and symptomatic treatment is sufficient, which includes oral antihistamines and mild to moderately potent topical corticosteroids, and they help in reducing the pruritus. And symptomatic measures are necessary for mucosal manifestations such as the mouthwashes with 0.2% chlorhexidine gluconate or tetracycline with or without nystatin, and topical anesthetics and topical corticosteroids and liquid antacids. So this is all essentially to avoid any infection by bacteria or candida, and even to reduce the pain during eating food, or also to reduce any gastritis. And ocular treatment is needed to prevent scarring and infection if there is involvement of the ocular mucosa. And early treatment of herpes simplex virus infection with oral acyclovir with the 200 mg 5 times per day for 5 days may prevent the development in case of recurrent erythema multiforme. Then prophylaxis with acyclovir 400 to 800 mg per day may also prevent episodes of both HSV infection and erythema multiforme. And if there is any secondary infection, antibiotics are necessary. Thank you. Subscribe for more.